Hi, everyone. Okay, common orthopedic problems or musculoskeletal. So just think about in utero, positioning can often produce muscle contractures and joint problems. So sometimes it's, some of the reasons why children develop conditions are either congenital, acquired, some bone malformations happen, or neuromuscular changes happen. So we know that neuromuscular maturation is important for normal musculoskeletal growth and development. Any process that produces an abnormality of the neurologic system can secondarily cause an alteration in musculoskeletal growth. So, things like fractures or abnormal growth patterns. All right, so nursing considerations of any condition affecting the musculoskeletal systems. We want to prevent any neurovascular damage or basically maintaining neurovascular integrity. We don't want any injury. We don't want an infection from a cast or traction or any falls, injuries from falls. And then we also have to think of a child who's immobilized can end up with some musculoskeletal deficits if they stay in bed for long periods of time, right? That's never, ever good. Here's the anatomy a little bit of the bone structure of a child. We know that the conversion of cartilage to bony structure is called ossification. And this begins in embryo and continues till they're 21 years old when the skeletal maturation, anywhere between 18 and 21, depending on male or female. Cartilage develops at the epiphysis and is capable of withstanding lots of tension. The diaphysis is hard shaft portion that makes up the major portion of bone. Ossification progresses outwardly from diaphysis to the epiphysis, layers of cartilage and bone-like, spongy bone-like structures located at the end of bones, the epiphysis. You could see the epiphyseal plate on this picture. This plays a major role in longitudinal. In other words, the bones need to go longer and grow longer. So we have to have this growth plate in order for growth to be able to continue with those bones. It is the weakest point of long bones, and the epiphyseal plate is located between the diaphysis and the epiphysis. Periosteum is thick, tough membrane that covers all bones and contains blood vessels that nourish the bone, the periosteum. So that's just kind of a quick anatomy of that, but characteristics of bones in children are bones are less dense, more porous than adult bones, not as strong, and they break much easier. And they can also bend and buckle easier. However, the healing is more rapid, especially, they basically can heal pretty quickly, depending on their age group, of course. It's inversely proportional to age. Stiffness of uninjured joints are unusual. Immobilization, though, for a long period without producing stiffness. So they can immobilize their joints and bones much longer without having issues with stiffness, but it's still not good for them. Remodeling occurs in the healing of long bone fractures before epiphyseal plate closes. So irregularities produced by fracture, the hollow areas are filled in and angles are rounded off. Those can cause irregularities. So we don't want remodeling to happen if a child has a bone injury with the epiphyseal plate that can cause permanent growth problems. So pediatric fractures are usually, trauma related, falling off swing sets, motor vehicle kind of bicycle accidents, that kind of stuff. We also have to look for other injuries in the child if they have a pediatric fracture of a bone. We want to look for bone disease because if they have like they fall off their bike, most kids don't develop a fracture from that. So we do want to look into, do they have any bone disease, like brittle bone disease? And also think about complications that can happen in children, just like adults, embolus, hemorrhage, all of these. So those are things that we need to be aware of as well. Fractures for infants, very rare. There is something called Osteogenesis Imperfecta, and this is caused by defective genes that affect how the body makes collagen, which is, of course, a protein that strengthens bone. Condition can be anywhere from very mild, type 1, with only a few fractures during a person's lifetime, or very severe, where it can occur without any apparent cause, but have hundreds of fractures. Treatment includes bone strengthening medications, physical therapy, and orthopedic surgeries as needed. We do have to also think of fractures in infants to be birth trauma and on child abuse. So whenever we see an infant have a fracture, we're going to think about, did they have birth trauma that caused it, or was it child abuse, or is it this osteogenesis imperfecta, which is, again, brittle bones related to a genetic disorder. Again, the types 1 through 4. Type 1 is the mildest common form of brittle bone disease. The quality of the collagen is not enough, but they still have some collagen formed. Children with type 1 typically have bone fractures mild to, due to mild to traumas. Bone fractures are less common in adults, of course. The teeth can also be affected, dental cracks and cavities. And then there's type 2, the more severe form, can be life-threatening. Body does not produce enough collagen, or collagen has very poor quality. And the child this can cause bone deformities. Babies with type 2 can die in the womb or shortly after birth. And then there's type 3, very severe. Bones break very easily. Even at birth, bones will be broken at birth. And the child, it just gets worse as they get older. And then the 4th type, the body produces collagen, but it's in poor quality, and typically the child is born with bowed legs, and bowing tends to lessen with age, but again, severe kind of a form. Okay. Those are very rare, though, the osteogenesis imperfecta. Okay. Fractures in young children, school-age children. Again, from various reasons, but kids can have bike accidents, skateboarding, scooters, all kinds of sports activities. Here are some of the pediatric fractures. If it's a simple fracture, there's no break in the skin. If there's break in the skin, they call it an open fracture or a more complex fracture. And children's bones can bend or buckle, which is unlike adult bones. And then green stick is the most common seen fracture in children in the forearm, green stick fracture. And there's a picture of it in here. If the epiphyseal growth plate is still growing, there could be this really, interruption with their growth and development of the bone. So again, there's different types of this Salter-Harris classification, but again, if a crush injury takes place and it causes cell death in the growth plate, they're not going to have any more growth or lengthening of that bone. It could be deformed. So that's why it's dangerous to have injuries of the bone in this end of the bone area during the time of growth and development. The other thing to keep in mind, immobilization of a child has to happen sometimes with casting or traction, bed rest or braces. But we have to really keep that child as active as possible, even when they're immobilized. So just keep that in mind. It's not healthy for children to be immobilized for very long. So we got to keep them active, keep them engaged in activities of play, doing exercises with them frequently so that they don't, have any long-term damage. CMS, this is something we can do with children during the cast, checking the color, motion, sensation. Don't let them stick small toys inside the cast. Don't use baby powder. And then remember that you have to continue with their developmental growth by doing teaching and playing, depending on the age. So, work on arts and crafts or homework from school, depending on the age group. The 5 Ps we've talked about before, because in the vascular unit, we talked about it, but of course this does relate because we don't want them to have vascular impairment. So we're going to be looking for all the 5 Ps whenever we have someone with a bone fracture. DDH, or developmental dysplasia of the hip. This is when the head of the femur is not seated correctly in the acetabulum. So you could see it in this picture, but there's varying degrees of hip dislocations. So this can also be a congenital issue or a developmental issue. So whether or not it happened in utero and we found it right after birth, or did this happen when they were growing and playing and their growth and development. Treatment goals is to realign, and we want to avoid any weakness of the hip muscles, and we don't want them to end up with arthritis or a decreased range of motion. We often, not often, we always screen infants for DDH. We look for things like asymmetry of the gluteal skin folds. There's always a test question on this one too, by the way. Asymmetric abduction, Alice and Ortolani's sign, and there's also called Galeazzi, which is the same thing as Alice sign. These are used to assess hip dislocation. It's basically a test they do. They flex the infant's knees when they're lying down. So they lie the infant down supine position, flex the knees so that the feet touch the surface and the ankles touch the buttocks. And then if the knees are not level, if the knees don't end up level, so they're looking at the height of the knees in this position, that could indicate a congenital hip malformation. Barlow and Ortolani, these are tests used to identify unstable hips. So Barlow's, the infant's placed supine with the hip flexed to 90 degrees and the neutral rotation. The examiner adducts the hip while applying a posterior force on the knee to cause the head of the femur to dislocate posteriorly from the acetabulum. A palpable clunk can be heard as the femoral head exits the acetabulum. So again, that would be an unstable hip. Ortolani identifies a dislocated hip that can be reduced. The infant is positioned in the same manner as the Barlow. The hip is gently abducted while lifting or pushing the femoral trochanter anteriorly. In a positive finding, there is a palpable clunk as the hip reduces back into position. So either one of these, both of these tests are done by the provider, by the physician. So we do not do them as nurses. If they find that the hip is dislocated, they'll put the child in this Pavlik harness to maintain flexion, abduction, and external rotation. Worn continuously for 23 hours a day, taken off only to, check skin integrity. Worn for usually 3 to 6 months. Lower extremity tissue perfusion, we have to monitor that. Again, skin is important to monitor. A lot of teaching with these harnesses and DD8